the Tonight Show, you know.
Yes, that's true. I remember that. That was a great theme song.
Here's Dr. Gersh. She received her medical degree at USC School of Medicine. She studied obstetrics and gynecology at Kaiser Hospital in Los Angeles, and she had the CREOG Top Resident Award, whatever that is, every year. She launched a private practice with a belief in holistic women's healthcare. You must have been an N of one. You must have been
I was ahead of the curve. I don't know how that
from
happened.
the earliest years way back before alternative medicine was popular. She included acupuncture, massage, and Chinese medicine. 20 years ago, she pursued her interest in holistic healing and graduated from the fellowship in integrative medicine at the University of Arizona. And she was dual board certified in integrative gynecology. And we're going to learn about assessing vasomotor symptoms, prescribing evidence-based menopausal hormone therapy, and integrating non-hormonal pharmacological options. I'm hoping that you'll touch on the the breakthrough that estrogen is no longer carcinogenic, according to the FDA, and all of the I'll call them harpies that have been lecturing us for the last 20 years and telling us, I've showed mine where I've been called a shaman, a fraud, a huckster, and a charlatan for prescribing bioidentical hormones. And the same people who I have quotes from them saying that it's all a bunch of hokum, or now they're all on the bandwagon. They're saying, oh, now it's okay. So I don't know if you have
Well,
any comments on that.
well, I will. Okay, spoiler alert. I am very pro hormones,
No, I
and
know, no, no.
I
Well,
know.
I
So I
am
am
too.
going to. I know. So yes, ditto 100 times over that
We talked,
hormones
yeah,
don't kill us.
yeah, we
And
talked
they don't
about
give
this
us
the
cancer.
other day. And I remember I told you I want to reach through the computer screen and choke some of them. This you go back
Well,
a year ago or 3 years ago, and they're telling you that everything that we've been teaching for the last 15 years is all a bunch of hooey, and now they're on board with it. So, um,
I know, and it is frustrating to say the least. And I have a long memory because I was around, what is historical interest to many who are practicing today is actually my memory. So I was around practicing when the Women's Health Initiative came out in 2002, and the when the what was called then the North American Menopause Society basically endorsed the whole concept of hormones are bad and you should get off of them, and if you have to use them as a last resort, it was the smallest dose for the shortest time. And now they're a little bit modifying, but not tremendously. But they changed their name, but I don't feel that they've changed their underlying identity. So I dropped out of that organization. I quit. I said I'm never giving them a penny again, and never will go to their meeting. So
they're funded by Big Pharma, right? You know that, right?
I figured most of them are,
Yeah.
but
You look at
they
their
were
funding.
also somewhat funded by the people who paid their dues, and I was not going to give them any money ever again. And they're still kind of slow. I mean, they're still not, they just never were champions of women's health. And I think that their organization is not the arbiter of anything. I certainly didn't elect them. So I much prefer hanging out with you guys.
Well, we
So.
much prefer you hang out with us also.
And so I want to talk about vasomotor symptoms and talk about what to do with them. And a lot of what spurs this on, even bringing it up, is because of some of the new pharmaceuticals that are out there. And they're really pushing a lot. I don't know if drug reps ever come to you, but they are talking a lot about trying to get people to use their pharmaceutical, okay, instead of hormones. So we're going to talk about these things. You saw that. Um, by the way, these I love color, and although I'm not wearing anything colorful today, I'm wearing a little sparkle. But if you ever go to Seattle, I forget the name of it now. Some of you remember that has this beautiful artistic glass from like an artist. Anyway, So it's not trademarked. So I can take pictures. I took pictures of these things. So I'm not breaking any, like I own this photo. So I can use that. So I decorate. So anyway, a fundamental that everyone should know is that to be optimally healthy, we're talking about women, but could be anybody. To be optimally healthy, you have to have optimal hormones. It's not like you could just say, let's take out your thyroid gland and replace it with meditation or even vitamins or vegetables. I mean, a hormone has an absolute necessity to be in the body at the right amounts and at the right time and with the right rhythms. And so hormones are not optional for optimal health. So, what about vasomotor symptoms? They're like the famous hot flashes, night sweats that are you know, the classic arbiters of you're probably going into menopause, and that those are the symptoms that most doctors now who are prescribing hormones prescribe them for. As I'm sure you know, like the Menopause Society, which I mentioned, used to be the North Menopause Society, and also the other international menopause organizations, the International Menopause Society, European Menopause Society, British Menopause Society. They're still about hormones for treating and reducing night sweats and hot flashes. They're not about optimization of hormone levels, doses, monitoring levels for optimal healthy longevity. That is not even on their radar. But, I have to say that getting reduced night sweats and hot flashes still has significant health benefits. But, it's not the amount that it takes of estradiol. And you can even use progesterone and I don't recommend just using progesterone in menopausal women. But even that and testosterone will reduce hot flashes, even at very small quantities, small doses. But that's not the same as creating growth factors that will grow bone, rejuvenate, create neuroplasticity, neurogenesis, control the cell cycle, and all the other things that estradiol does. It's just not going to happen if you give tiny doses to suppress night sweats and hot flashes. And it's not like there's a small number. This is over the next 20, 25 years, it's estimated that there'll be 1 billion women that reach the age of 50. I'm sure many of them are currently living in China. But there's like lots of the population are going to be affected by what we do as, doctors. So what about menopausal vasomotor symptoms? Well, they're incredibly common. It's like 80%. Some people think it's more. It depends on how much you count them, if it's like barely there or not there. But it's the vast majority of women will go through menopause experiencing some degree of hot flashes and night sweats. And they're very, very severe in terms of affecting quality of life in many, many women. And it can occur with very tiny changes in the core body temperature. And that's what it's all about, trying to maintain. It's essential that the core body temperature, the inside temperature of your body, be held at a very consistent level for all the organs to be working properly. It's not like you can have varying temperatures all over the place and it can be different amounts. It's really critically important that you maintain a steady, secure, optimal temperature in your core body. And the body works really, really hard to maintain that optimal temperature. And even small swings, the body it becomes desperate. So it creates vasodilation and you get the flushing and the flashing and the sweats. So it's a really, really big deal. There's a funny blue line on here. I don't know where that came from. So when these temperature swings are happening, even with these tiny temperature changes in the core of the body, you get overwhelming heat sensation, sweating. I don't know if even men sometimes will be sick and they'll have, these temperature changes. And there's certain viruses or other infectious pathogens and so on can create night sweats and hot flashes. So it's not like it's unheard of in men too. But when you have changes in the core body temperature, the body like works overtime to try to get it back to a normal temperature for survival. And so these are the areas, the upper back, the chest, the head, the neck, that will experience all of this incredible sweating. And the episodes can happen so many times during the day. It's like day and night. They call them night sweats, but they can be all over the time of the 24 hours. And they can last for at any time when they occur. That usually they'll be 1 to 5 minutes and then followed often by very severe chilling. Does anyone know why I have those blue lines? It's like really weird. They weren't there when I made the slide deck. But hot flashes and night sweats don't live in isolation. They're very disruptive and they're associated with a lot of mood changes, irritability, anxiety, depression, sleep problems, focus, memory issues. And the number one symptom that women complain of as they are going into menopause is actually word recall and memory problems. And they're completely interlinked. And you could also say you can't separate any of this out, can be related to having problems with sleep. Of course, if you're waking up multiple times during the night with horrible sweats, and then often the bed can be literally soaked in sweat, and then you start shivering and you're like freezing and you're in this moisture zone, and people are changing their pajamas, they're changing their sheets. I mean, it can be that severe. It really, really can. And these symptoms can begin years before the so-called official menopause, which is defined as 12 consecutive months without any bleeding from the vagina. And it can happen years before, and it's often not even recognized or appreciated that if you think of what's the normal menopausal age, well, it's in the US, it's anywhere from 45 to 55. That's a big decade. When is perimenopause? It starts officially, and of course, there's a lot of variation individually, 10 years before that final year following the last period. So if you have an earlier, it's still called normal, a menopause at 45 or 46, you are a woman in perimenopause and you could be 35 or 36. Now, what if you have an early menopause? So early menopause is 40, just up to 45. Premature is before the age of 40. Late is after the age of 55. So it's not an insignificant percentage. It can be like at least 10% of women will have an early menopause. So what if a woman is 43? I can tell you I was 43, and I attribute my early menopause to the fact that I had a baby at 39 and everything was fine. And then I had a postpartum tubal ligation. And I did not know this myself. We weren't taught this, that even a tubal ligation can impact ovarian function, alter the blood flow, and trigger early menopause. So I had a tubal ligation and I nursed my baby, and then I never got periods back and I was in menopause. And so there you go. And so luckily I didn't believe any of the negative hype about hormones, and I went on hormones immediately, or I don't know if I would have a brain functioning anymore. But so for women, you've got to think of it. I know you guys do, but I'm talking to people who maybe are new and didn't know this. If a woman starts saying that I'm having problems, I'm having more anxiety or depression or focus problems, memory problems, sleep problems, and I'm getting sweats, you don't have to have all of these. You can have any or all of them. And they're having night sweats or hot flushes or just sweaty or just feeling off, and they're 33. They could be still perimenopause. They could be 35. They could be 38. So like all these ages could be the onset. So it can happen years before, and things are happening that are hidden as well, involving the cardiovascular system, the brain, the bones, and so on, starting years before that official final period. Now, what about the symptoms, the vasomotor symptoms of the sweats and the flushing? Well, it can go into the 70s. I actually saw, after I made this slide deck, there were reports of women into their 80s who are still having menopausal related night sweats and hot flashes. They're not like gone in a flash. They can go on for years, and I'll show you. And it's like the number of women that are not getting treated is gigantic. The majority get no treatment whatsoever. I'm sure you see them. They show up and you can't believe that they've already seen doctors before they came to you and they did absolutely nothing. So as I mentioned, the core body temperature needs to stay within a very specific range, and it's very, very narrow. And it can oscillate, though, with the daily circadian rhythms. And you probably know this when you have little children, and if they get sick, they tend to get a fever at night. So temperatures do change a little bit with circadian rhythm. Of course, they can be magnified if you have illness. And the body does everything it can to try to maintain that proper core body temperature. It will do anything it can to dissipate heat if the temperature is rising. And as I said before, the maintenance of optimal internal organ function relies on this tight regulation of the core body temperature. And there's a section of the brain in the hypothalamus that's called the thermoregulatory center that helps to regulate the core body temperature. And when you have disruption of it, and you have this problem with disruption in the brain that's due to loss of adequate estradiol. I want to make sure you know that it's loss of adequate estradiol in related to in menopause that causes this tremendous problem with vasomotor symptoms because the thermoregulatory center in the brain is modulated by estradiol. There are receptors to estradiol throughout the whole brain and many, many receptors in the hypothalamus. And that's where the thermoregulatory center is located. And so you get to try to regulate the core body temperature, you get these crazy, exaggerated heat loss responses. And it was shown that, interestingly, in the SWAN study, that they showed that you get higher vasomotor symptom numbers when you have very high FSH levels and low levels of estradiol. So there may be something to do with FSH levels as well. There's still lots to be learned actually about this. Now, I want to introduce the neurokinins, and the neurokinin that has been what are neurokinins anyway? They're peptides. You know, you've been probably talking about peptides a million times over, and it's a peptide. So neurokinin B is a specific peptide, and it binds to certain receptors, as these things do. And one receptor is called the neurokinin 3 receptor. And the neurokinin B can bind to the neurokinin 3 receptor. Now, I'll jump ahead and just tell you that there's a new drug that just got approved. It's not marketed yet, but it just got approved. I can never remember the name because obviously I'm not prescribing it, but let me just tell you it. It's called, the generic name is elinzanetant, and the brand name is going to be Linquet. Okay, so it is a dual neurokinin receptor antagonist for the neurokinin 1 and 3 receptor. All of my slides are talking about the 3 because that's the only drug that's currently actually on the market to deal with this, which is Veozah. The generic name is fezolinetant. Okay, but the new one that just got approved, and I'm not really particularly recommending them, but I'll tell you where there might be a use for them, because estradiol is, of course, the gold standard in how to modulate and reduce and control vasomotor symptoms. There's no question that that's the gold standard. But there is these blockers of the neurokinin 1 and 3 receptors that neurokinin B, that's the peptide, can bind to. So it acts as like a neurotransmitter. You know, peptides are like can be neurotransmitters, and that's what it sort of acts as. And it's found in the hypothalamus amongst what are called the Kindi neurons. That's in the hypothalamus. And it binds, the neurokinin B binds to these neurokinin receptors. It binds to several. One as number one, and another one is number three. And they are the neurokinin 3 receptors are G protein coupled receptors. You probably heard of that. They are expressed on neurons, including the so-called Kindi neurons that control thermoregulation. And so there's this crucial signaling pathway that's in the hypothalamus that's called the NKB, that's neurokinin B slash NK3R, neurokinin 3 receptor pathway. And so when you have neurokinin B binding to its receptor, neurokinin 3 receptor, it triggers certain effects that, of course, are very important for more than one thing. Nothing is about one thing. And it triggers, among the kisspeptin neurons, is the production of rather the Kindi neurons, is the production of another peptide that you may have heard of called the kisspeptins. And the kisspeptins, which come from the Kindi neurons, is very, very also important in reproduction. It's the kisspeptins that come from the certain centers in the hypothalamus that trigger the production of the gonadotropin releasing factors that then go to the pituitary that trigger the production of the gonadotropins, luteinizing hormone, and follicle stimulating hormone. So this is the centers that control the thermoregulation of the body is also related to control of reproduction. So it's like all interconnected and very, very critically important. So I always say that everyone should know the prime directive of life is the creation of new life. Whether you want to have babies or don't want to have babies, that's a personal choice. Only humans, they're the only species that actually tries to control their reproductive destiny. There's no other animal that I know of that would say, let's not have babies this year. Let's just not mate. I've never heard of that happening in any other animal species. And the temperature thermoregulation is clearly really important for the reproductive processes because they're located right together and there's overlap in their peptides, like the kisspeptins from the from the Kindi neurons. And in fact, neurokinin 3 receptor regulates the gonadotropin releasing factors, or here it says H for hormone secretion, that causes the release ultimately of LH, luteinizing hormone, and follicle stimulating hormone, FSH. So it's so critical that the core temperature being maintained for proper ovulation, reproduction, implantation, all of this is really critically related to the core body temperature. So these factors, these receptors, and these peptides are all completely interconnected in that area. So they're related to regulating body temperature. So body temperature and maintaining that proper core temperature is critically important for proper reproduction to occur. So I've already kind of touched on this, that you have dysregulations in the thermoregulatory system that are in the hypothalamus that, create this temperature dysregulation. In terms of the Kindi neurons, and you may have heard of these things, they're involved with the peptides called kisspeptins, the neurokinins like neurokinin B, and another group of peptides called dynorphins. Okay? And if you have overstimulation because estradiol is not regulating it, then you get during the menopausal transition, you get dysregulation of your core body temperature. And then, the body does everything it can to try to keep the temperature proper by having less heat, more heat, and it just becomes really wild. And the temperature in the skin is going to be very affected. And when they've done studies looking at blood flow to the skin, it's like all over the place. You can really see changes in blood flow to the skin. Because the temperature of the body is desperately trying to be maintained at that proper core body temperature. So you can have alternating vasodilation or constriction. And it's such a maladaptive way of having temperature homeostasis because the body just can't control what's going on in that thermoregulatory center. And so to try to maintain temperature, it's going to have more flow, less flow. And you see changes all the time in the blood flow to the skin with alternating and variable vasodilatation or constriction. And then you can get the heat, and I mentioned, followed by profound chills. So it's very, very challenging. I don't want to go into it and like beat this to death because I just want you to really get the takeaway that the hypothalamus is involved in progesterone receptor function and estrogen. I don't really get into progesterone too much, but I'm sure many of you know that when progesterone, like, do you remember the days, if you were old enough, when people did basal body temperature thermometers? You remember basal body temperature, where they're trying to get basically looking at the core temperature by doing trying to take the temperature first thing in the morning before you got up or moved or anything to see if you were ovulating before we had all these ovulation kits and more scientific. That's the advantage of being older. I lived through basal body temperature thermometers, and people would know that when progesterone, after you ovulated and progesterone was produced, you would have this tiny rise in temperature. This is like really little because progesterone would raise the temperature just that little bit. And it's all regulated through the centers here in the hypothalamus. And that's been well known that progesterone will raise the temperature just this tiny bit that you could detect on your basal body temperature thermometer. And but this is another important takeaway that the temperature when it's dropping, okay, and it affects the hypothalamus and the temperature, the changes in, I shouldn't say the temperature dropping, sorry, when the ovarian hormone levels are dropping, they will impact the area of the hypothalamus that we're talking about. And it interconnects with the production of other neurotransmitters, serotonin and norepinephrine, which are also involved. It's very complex. So it turns out that there are these downstream effects. We have the really local, and then there becomes more downstream. And serotonin and norepinephrine are also involved in serotonin, which comes into play when you look at the therapeutic pharmaceuticals that are used to modulate and try to lower the vasomotor symptoms. So what about these other neurotransmitters? Well, estradiol influences serotonin and norepinephrine synthesis and the synaptic binding, the density of the synapses, and the neurotransmitter reuptake and degradation. Estradiol is like a drug. It actually does the same kind of thing like Prozac. Estradiol is actually a reuptake inhibitor for serotonin. And it also acts on the serotonin receptors to improve their function and is involved in serotonin production, but also norepinephrine synthesis. So these are really important to know because estradiol is very critical of all the different aspects of brain health. And these neurotransmitters, serotonin and norepinephrine, are also involved in temperature regulation. And estradiol, as I mentioned, is involved in the expression of serotonin and neuroepinephrine receptors. And when you have disruption, when you have low estradiol, you end up having disruption of the production and function of these vital neurotransmitters, norepinephrine and serotonin, which then goes downstream to create even more thermoregulatory disruption. That is why you can give SSRI drugs to try to treat hot flashes and night sweats, the vasomotor symptoms. And I bet you know that. I'm going to have a slide on it, that the SSRI drugs are used many times for treating hot flashes and night sweats, and also the SNRIs. And we'll talk about that in a moment. So now there's a few other ways that have been talked about with what could be involved in vasomotor symptoms, which we won't get into too much of, but there's other areas in the brain that may be involved as well, including the brainstem. And they've shown that there's some different activation in areas, the insular cortex and in the brainstem. So whatever we're talking about, it's probably significantly more complex in how everything is more complex than what we think. And it's so important that we realize that whatever all this complexity is, that estradiol is the master modulator of the entire system. Now, I've actually mentioned quite a bit of this already, so I won't get into that. Now, we talked a lot about some of the other things that are involved in vasomotor symptoms that come like ancillary. Well, I mentioned sleep disturbances. I mentioned depression. Now, I'm going to tell you a very personal story that I share hardly ever because I never think that things are about me. But in this case, I really want this to resonate with you. Vasomotor symptoms can be life altering and life disrupting. So here's my personal story that I want to share with you and why this is so important to me, that you understand the basics of vasomotor symptoms and that this should never be ignored. They should never be ignored. Well, it turns out that my father's mother, so that's my paternal grandmother, when she went through menopause, she had horrific night sweats and hot flashes, the worst kind of vasomotor symptoms ever. And she did not have a history of anxiety or depression, but she became both anxious and depressed and could not sleep. So she went years. So, and we'll talk about it, the incidents, the time frame. Well, I'll just jump ahead. I'll tell you, the average woman can have night sweats and hot flashes, vasomotor symptoms for 7 to 10 years. And these are not like insignificant problems. This is huge, and they're associated with so many other things. So my grandma, who I never got to meet, I am named after her. I am named after that grandmother who I never got to meet. She apparently spent years, she was already something like 7 years straight, having horrible, really horrible night sweats, hot flashes, sleep disturbance, and there was no treatment at that time. There was nothing that anyone could offer. My father told me that he would put her in the car. They lived in an apartment building in Brooklyn, New York. He would, when after like evening came, he would put her in the backseat of the car and he would drive as fast as he could all over the streets when there's not too much traffic with all the windows open in the car to try to help cool her down because that would be the time. And they bought fans, as many fans as they could. There was no air conditioning and there was nothing to cool her down. So he would drive for hours with the air blowing on her in the car, going as fast as he could to try to help her to feel better. One evening, it turned out that my father and his youngest brother, he had two, his youngest brother, were visiting and in the apartment with their parents, my grandfather and grandmother. And some stupid argument developed. That nobody knows what it was anymore, but some stupid argument developed between the younger brother and his mother, my grandmother. And it was just some kind of really unimportant, but it was an unpleasant argument about something or other. And for no, obvious reason, nobody really noticed. She just, said, "Excuse me." She got up from the living room, walked into the bedroom, opened the window, and jumped out of the window from the fifth story and died. She jumped out the window. My grandmother committed suicide. And she's never had a history. She was suffering, my father told me the whole story, the most horrible night sweats, hot flashes for years. No treatment was available. She had an argument. She had developed depression, and she committed suicide. That's how things can really happen. Women have just been suffering for so long. That's why this is one of my missions in life, to help people to understand that yes, some people have very mild symptoms, but some people have really, really severe. And look at the cost. I mean, the cost is humongous for what happens to these women, and it's involved in poor endothelial function. So night sweats and hot flashes are not just, well, you get wet and your clothes are damp. I mean, the people can't sleep. They have medical problems. They have cognition problems, vascular problems, increases atherosclerosis, and increased risk for diabetes. When women who have higher incidence of vasomotor symptoms have a higher risk for developing diabetes. So there's plenty of data. This is from the Women's Health Initiative. One of the offshoots showed that women who had the worst hot flashes had the biggest chance of developing type 2 diabetes. Now, who's most likely to get terrible vasomotor symptoms? Well, it turns out that African American women are the most likely to have not only the worst vasomotor symptoms, but also the longest duration. Can you believe this? The median number of years that they suffer with vasomotor symptoms is just over 10 years. And it was something like 7 years out of suffering before my grandmother just got so upset she jumped out a window. And it turns out that Chinese and Japanese women have the least amount. Now, some people think, and it's hard to prove because it's hard to get a study or something about on this, that they eat a lot of soy. And soy is a very good phytoestrogen. And they start very young in life. And there's actually a study that I don't have in my slides that was done by the cardiologist who's a vegan, Dr. Neil Bernard. And in his study, he gave women a cup of soybeans to eat every night. And they were for 12 weeks, women with very significant vasomotor symptoms. And at the end of 12 weeks, the women had dramatically reduced vasomotor symptoms from eating a cup of soybeans every day. So that's probably the secret sauce that keeps the Chinese and Japanese women to be the least likely to have these terrible night sweats and hot flashes. So the mean duration of all women is 7.4 years. That's a lot of years. And, I told you the story. My grandmother was like around 7 years out, and she was going just like they had just started. And there can be, like I mentioned, that they can start years before the actual official menopause. And when premenopausal and early perimenopausal women developed vasomotor symptoms, they tended to last longer. So women who start having these symptoms before they're actually in official menopause, their duration on average is almost 12 years, with an average after the final menstrual period lasting almost 9.5 years. So I think this is underappreciated how serious this condition is and how many years it can last. Women who are postmenopausal, they're already, haven't had any periods for at least a year. And then at that point, they developed night sweats and hot flashes. They tend to have the shortest duration, which is still almost 3.5 years of suffering with vasomotor symptoms. I mean, come on, this is like absurd, right? By the way, I have no idea why all those little blue lines are on my slide deck. Anyways, and this is from the SWAN study, the study of women's health across the nation. And this went over 17 years. And they found, just like what I was said, and that was from the Women's Health Initiative here from the SWAN study, they found that factors related to longer duration of vasomotor symptoms was younger age at onset, also lower educational level, greater perceived stress and symptom severity. So if women are already in bad shape, like they found with emotional problems, women who have a prior history of any kind of emotional problem, whether it's postpartum depression or PMS or general anxiety disorder, things like that, when they go into perimenopause, their chance of having a clinically significant psychiatric problem goes up 400%. But women who've never had a single problem, like my grandmother, their chance goes up 200%. So it's not a little issue here. And the worse they are going in, the worse the vasomotor symptoms. And then they'll have the women who have higher depression or higher levels of anxiety prior to going into menopause will tend to have worse vasomotor symptoms. What are some other risk factors? Obesity. So it turns out that obesity is a significant increased risk factor for having severe vasomotor symptoms, and weight loss can definitely help with that. Smoking or exposure to secondhand smoke can also be a problem with a 60% increased chance of having significant symptoms. And as I mentioned, pre-existing mood disorders, childhood abuse. It seems like children of trauma, children who've had problems of any kind of childhood trauma or abuse, their ability, their resilience is very reduced. And that includes for vasomotor symptoms. And like I mentioned before, lower economic status and educational levels. So let's talk about the pharmaceutical types of therapeutics. I already mentioned SSRIs. So it turns out that you may have heard of the SSRI called paroxetine. That is actually FDA approved for treatment of vasomotor symptoms. So that's kind of interesting. But off-label, pretty much any of the SSRIs are used, and that would include fluoxetine, that's Prozac, and citalopram, and I never say the generics, so that would be Effexor, citalopram, and sertraline. Okay, so all of them provide basically similar benefits. All of the SSRIs are going to be similar, and the SNRIs as well. Actually, viloxifene, that's Effexor. And so the other one that I mentioned, that's actually Lexapro. So I'm still stuck on the branded names, but escitalopram, that's not quite how you say it. That's Lexapro. So, and Effexor, which is an SNRI, is also effective because now you know that they work through the systems involving these serotonin and norepinephrine work also in the thermoregulatory centers as well, involved with estradiol. So what about off-label? Off-label, those are on-label. Off-label are gabapentin and clonidine. Clonidine is usually pretty much shunned now and not really recommended. Gabapentin is still being used of quite a bit, and there is supportive data. It's not FDA approved, but there are studies showing support. And it's important to know the non-hormonal treatments because there can be, I'm like estradiol gold standard, but there are some cases where you have contraindications, whether they're right or wrong. Generally speaking, it would not be given, you wouldn't be giving estradiol to a woman who was just diagnosed with estrogen receptor positive breast cancer or endometrial adenocarcinoma. So usually, you're not going to be doing that. And then there are some women that probably or really should be able to be on estradiol, but they do have contraindications in the conventional medical world, and people may not really wish to go sort of outside those boundaries, and they're not comfortable giving it to a woman who has maybe homozygous for factor V Leiden. To me, that's not a contraindication, but other people would say that it is. Women who've had a prior pulmonary embolism or deep vein thrombosis, which I also don't really feel is a contraindication, but many people do. And that officially they are listed as absolute contraindications. So I'm not going to tell you to go against absolute contraindications. I'm just adding my own little off the beaten path opinion. Okay, so I want to make it very clear what's my opinion versus what is a standard recommendation. So for the issues that are considered standard recommendations, never as an absolute contraindication, do not give estradiol, do not give the hormones, then you need to know about these other treatments that are available for your patients, because I never want you to ever see a patient who has vasomotor symptoms and they leave your office untreated. I know that would never happen, but it happens to women. I see them every day, and I'm sure you do too. So it shouldn't seems like it can't happen, yet it does happen. So just as a quick recap, and then we're going to talk about integrative approaches. We don't really know everything about what's going on. It is very complicated, but it definitely involves the neurons that co-express for the peptides, the kispeptins, neurokinin Bs, and the dynorphins, known as the Kindi neurons. And estradiol, the gold standard, is what innervates the thermoregulatory center in the hypothalamus and controls these peptides. So I'm sure you've all heard of peptides, and you may think, well, what is the trigger to the production of peptides anyway? Like, what causes peptides to be made? Like I mentioned, kispeptin, these peptides that are from the Kindi neurons that are involved in reproduction and the thermoregulatory center of the hypothalamus. Kispeptin, neurokinin B, dynorphin. So what triggers their production in the first place? Well, it actually is nutrients for kispeptins. So that's why women who are anorexic will tend not to have menstrual cycles, because the centers in the hypothalamus that have certain clusters of neurons, they have centers that are sensors for nutrients. And those nutritional centers that sense nutrition status will help to produce proper kispeptin production in the proper way to have cycles and to have reproduction. In addition, light and dark. So that's why circadian rhythm and living in the same time zone and going to bed at the right time is really important for women to have proper temperature regulation, proper reproduction. And estradiol is really critical. Estradiol is the modulator of all of these peptides being produced. So it's really important to realize the incredible role of estradiol in the production and regulation, modulation of these critical peptides in the brain that are involved in both thermoregulatory functions and reproductive functions, and that they all interconnect, because it appears that having proper regulation of the thermoregulatory zone is critically important for effective and optimal reproduction. And even though the mechanism is not completely clear, when you have a decline in estrogen production with menopause and perimenopause, then you have an alteration, a dysregulation of the peptide neurokinin B signaling involving the peptide neurons in the thermoregulatory zone, and you get these crazy hot flashes as the brain is desperately trying to maintain proper core temperature in the body. And you get these crazy changes in, like I mentioned, you get constriction and dilation of vessels alternating in how the blood flow to the skin is happening, and so on. And by antagonizing or blocking the neurokinin B of the Kindi neurons in the hypothalamus, you can dampen the signaling that is responsible for this craziness that happens. And this drug, Veozah, fenzolinity, and the new one that's coming out is can help. And the studies with fenzolinity, Veozah, the brand name, is that they're not as good. They don't have direct studies. Actually, of course, they don't have a direct study comparing these drugs to estradiol. They wouldn't do that. But if you look at it, estradiol is definitely better. I mean, way better. The drug can reduce the night sweats and hot flashes about 50%. It's not as good. It's not the right thing. So if we look at the drug Veozah, so it's a non-hormonal selective neurokinin 3 receptor antagonist. So it's blocking that receptor, the 3, and the new drug, as I mentioned, just got approved, not yet on the market, is going to be a 1 and a 3 blocker of the receptor. Now, I don't know for sure what the current price is of Veozah, But the last I heard, it was not being covered by any insurances unless you did all kinds of jumping through hoops of fire to do prior authorizations. And without that, the the general price was like 600 a month, so not very cheap. And it reduced this. It took weeks and weeks to reduce the symptoms. It didn't happen like they said that there's some benefit in a week, but honestly, when you look at the data, it took quite a few weeks to get really significant benefit. So they do, of course, did a study, and in the study it said that their conclusion was that this drug, fezolinetant, provides a meaningful clinical benefit for women with moderate to severe vasomotor symptoms associated with menopause. And so this was a lot of hoopla that came out with this drug. And I'm not saying it has no place, but there are some issues with it. So in terms of this is their own from their study and their conclusions, sponsored by the drug maker, that they said that that it was similar to estrogen. But when I looked at the data, I mean, and you use estrogen. To me, estrogen is dramatically better. Plus, you would never use a drug like this unless you could absolutely not use estrogen, because estrogen is so much better. And it's really important to know that estrogen affects organ systems in all over the body. Only estradiol, when you give estradiol, do you have decrease in all of the bad things, decrease in dementia, osteoporosis, decrease in cardiovascular problems, and all the different things, joint issues. This drug only works in this one place with this one peptide receptor blocking. It's not really working in that one place. I shouldn't say that. It's blocking that receptor everywhere in the body, which can lead to some serious consequences, which I'll go over in a minute. But it's not having impact on estrogen receptors anywhere at all. It's just working on this one neurokinin B receptor, which as an antagonist, which is the receptor 3. And it's only working that one peptide. It's blocking that one peptide. So this is kind of crazy. It's not doing anything for any other organ system in the body. It's not doing anything that's going to prevent all the bad things that we associate with aging. So what's the problem? Well, we know that peptides are not doing one thing in one place of the body. Peptides are all over the place, and they do different things in different parts of the body. You have different levels of different peptides, even in the same organ, like in the brain. You can have one peptide, like oxytocin, could be in very different amounts in different sections of the brain simultaneously, while having totally different levels elsewhere in the body and doing different functions in different parts of the body. Well, the same thing with the neurokinin peptides. So it works in the liver as well. So unfortunately, if you block this peptide receptor in the liver, you can have serious liver injury, and you can't control it. You can't say only block in the thermoregulatory center of the hypothalamus. It doesn't work that way. When you give the drug, it goes everywhere. And in the liver, when you block that receptor, you can have serious liver injury. So now they have a warning. The FDA issued a warning for the drug, and it's now required before you prescribe the drug to check the liver enzymes, and then you have to check it every month for the first 3 months, and then at 6 months and 9 months, and thereafter, as they say, as indicated. But so you have to tell patients that if I give you this drug, I might really harm your liver. So livers are not optional. So that's why this is not my favorite. I would rather, if I had to use a drug because I couldn't give estradiol, I would personally start with an SSRI or an SNRI. That's where I would start. And then I would probably go to gabapentin before I would go here to this drug. But I'm going to tell you there's some supplements that honestly I would use first, which one of which I actually developed, but I'll go over that. So the gold standard is hormone therapy. Okay. And I know you all know that. And we started before I talked, having a little love fest about hormones because we love them so much. And they are the most effective agent, of course. And it's estradiol that will maintain the optimal function of every organ system, including the hypothalamus, the brain, and the thermoregulatory centers. And it maintains the proper neurotransmitters, neuromodulation, so that the synapses are working properly and that you don't have to have the crazy night sweats and hot flashes to regulate temperature. Now, what about what other things can you do? I already mentioned soy, and people like are malicious to soy sometimes. So processed soy pretending to be who knows what, some other thing, soy pretending to be chicken, or soy pretending to be ice cream or some kind of weird cheese or something else. Okay. I call that faux food. Actually, I didn't come up with that. It's called faux food, you know, and sometimes vegans do that. They use soy to try to think that they're eating turkey or a burger, or that it's not the same, and they use a lot of processed soy. But if you use organic unprocessed or minimally processed soy, it's really healthy. It has tremendous amounts of the phytoestrogens, okay, the isoflavones, which are really helpful. I mentioned Dr. Bernard's study. So what kind of soy should people eat? Like tofu, miso, tempeh, and you can also do, of course, edamame, the actual soybeans. So those are healthy foods, but soy pretending to be that's it. That's it for soy. Anything else is to process. Flax seeds. Now, these are phytoestrogen foods. Flax seeds have lignans. The soy has isoflavones. And the flax seeds have a lot of these lignans. They're very, very healthy. But also, if you don't want to have soy, if you don't want to have flax seeds, all beans, remember soy bean, it's a bean. So all the legumes, like whatever kind of bean you like, will have phytoestrogens that will help with night sweats and hot flashes. And not if you don't like flax seeds, any seed and any nut will have some amounts of lignans. But they're all vegetables and fruits have phytonutrients and polyphenols, and many have phytoestrogens. And I think of phytoestrogens as nature's gift to women at every age, and especially in perimenopause and menopause. Because phytoestrogens, which are not estrogens, but they bind to estrogen receptors and can give a lot of the same benefits, are amazing. And these are the things that you can use in women who have absolute contraindications that you just don't feel comfortable. You're not going to give them hormones. And that would be like active treatment for breast cancer, or they've had, like in most cases, they've had a PE or a DVT, or they have uterine cancer, or there are other indications for absolute that you'd be very cautious, or maybe you don't want to give hormones, or the patient doesn't want them. So these are things that we should do, is give them lots of phytoestrogen foods. Now, what about phytoestrogen supplements? Well, there's one that is from the Siberian, and there's others now on the market too, but I'm familiar with this one from the rhubarb, the root of the Siberian rhubarb, and it's in the family of phytoestrogens called stilbenes. So stilbenes are resveratrol is a stilbene. I'm sure you've heard of resveratrol, and there's a phytoestrogen, and there are studies with this product, the Siberian rhubarb, that is really, really good. And when I looked at the data, there's no, of course, comparison studies, but it was, to me, when I looked at the data, of course, they're run differently, the studies, that the rhubarb product, this phytoestrogen, did better than Veoza did. And this is a very safe supplement and very inexpensive compared to that drug. And the lignones, the isoflavones, and I don't know if you know this, but ashwagandha is a phytoestrogen, and there's studies to show that ashwagandha can help with vasomotor symptoms, and it's also very calming. It can help with sleep. So even if women are on hormones, no matter what we do with hormones, it's not going to be the same as being 21. Let's be real. We're not giving them a new set of pristine 21-year-old ovaries. We're doing the best we can with hormones, but we still need some adjunctive things. And ashwagandha is like the universal herb. If you don't know anything about herbs, learn about ashwagandha because it has so many amazing functions. It can help with sleep, with hot flashes, with mood. And ashwagandha, because it's a phytoestrogen, there's published articles that can help to prevent osteoporosis. So, learn ashwagandha and avoiding like alcohol, caffeine, spicy foods, and avoid. I told you smoking is an issue. Try to avoid secondhand smoke. And for women, dress in layers so that they're going to get hot, they're going to get cold, they're going to get hot, they're cold. So and have it's but there was an article in the New York Times a few months back, maybe it's a year ago by now, that talked about the problem for working women when they're going through menopause and they're getting these vasomotor symptoms that they advocated for like restrooms, like
100 pesos na po na bills yung pwede na po nilagay.
100 pesos.
Yes, yes.
Pieces. So, pero pwede.
I don't know what's happening. Well, anyway, um, so in that study that they reported in the New York Times, they recommended that companies should have accommodations to women who are going through menopause to give them places to change their clothes and so on. And I'm not saying that that's a terrible idea, but the best thing to do is give those women hormones or some kind of treatment. Don't just tell them to keep changing their clothes every time they could have 20 night sweats, or we'll say they're day sweats and hot flushes and sweating throughout the day, and they can't just bring in 20 different changes of clothing. So these women need treatment more than they need like workplace accommodation. But women should dress in layers when they're out and about until their hot flashes are controlled. Sipping cold liquids and sucking on ice is very helpful. And everything that they eat that's plant-based is going to have some phytoestrogens, reducing inflammation, neuroinflammation, nurturing the gut. Now, we're going to talk in a minute about the vasomotor system involved with the autonomic nervous system, and weight loss, exercise, and cooling pillows and sheets. All these things are out and about now. You can get cooling beds and sheets and fans. Now, talking about the autonomic nervous system, there's the two parts, the sympathetic and the parasympathetic, and these become quite dysregulated during menopause, and it's involved as well with the hypothalamus and the thermoregulatory center. And when you have dysregulation of the vagus nerve, estradiol modulates the neurotransmitter of the vagus nerve, which is acetylcholine. If you don't have enough estradiol, the vagus nerve will not be functioning properly, and you'll have loss of vagal tone, and you have sympathetic overdrive. The sympathetic nervous system is modulated by norepinephrine and epinephrine as its neurotransmitter, and that will be overactivated, and the vagus nerve will be underactivated, and you have this sympathetic overdrive. So you then have menopause associated just from the autonomic nervous system dysregulation with inflammation, sleep disturbances, hypertension, gut microbiome dysbiosis, and obesity and appetite dysregulation. And all of this is related to the hot flashes and night sweats as well, because the vagus nerve activates and is involved with the hypothalamus as well. And the thermoregulatory center is as well related, and it can give you palpitations. The autonomic nervous system is very key for heart rate, and this is all interconnected. I want you to know that the autonomic nervous system is also linked in to the thermoregulatory centers, and it becomes dysregulated. And if you look at this, you see that there's a host of different symptoms that are related to autonomic dysregulation. And if you look under, this is a little bit blurry, but if you look under the area that says CNS, you'll see that it says anxiety, fatigue, brain fog, pain, vertigo, so all these headaches, sleep disorders, daytime sleepiness, tachycardia, palpitations, POTS syndrome, overactive bladder, incontinence, cold hands and feet, problems involving sweating, like say hyperhidrosis, dry mouth and eyes, all these different gut problems, constipation, irritable bowel syndrome, dry eyes, all of those things. Those are all heavily related to the autonomic nervous system and actually are connected to vasomotor symptoms because they're all interconnected, it turns out. That's why when women have hot flashes and night sweats, we now know that those women have significantly higher risk for having heart attacks, strokes, dementia, osteoporosis, because all these systems are completely interconnected. That's why giving human bioidentical hormones is by far superior to any of these other drug symptoms that just might suppress somewhat the vasomotor symptoms, but the vasomotor symptoms are like the tip of the iceberg of what is really going on in the body. So in order to support the vagus nerve, there are vagus nerve stimulators, laughter yoga. Look that up. There's a whole laughter yoga association. Laughing actually is a vagus nerve stimulator. Different forms of meditation, breath work, singing, chanting, gargling. I don't know anyone who's doing gargling. Cold plunges. That's the mechanism of acupuncture. That's why acupuncture can also help to reduce night sweats and hot flashes. Massages, different essential oils, working on the gut microbiome can also be beneficial. Everything that you can do to support circadian rhythm, like time when you go to bed, it should be at the same time, making the room really dark, watching the sunset. Adrenal adaptogens like ashwagandha is very, very helpful. Omega-3 exercising can be helpful. And just having friends and doing things that make you happy can also help. The gut microbiome is also associated with night sweats and hot flashes. In fact, this is an article that is here that's referenced that hot flashes can be related to increased gut permeability. So it just shows you how complicated all of this is, that all these systems are so interconnected. Loss of estradiol is very key to having gut dysbiosis. And here's a study that showed once again that hot flashes significantly were associated with impaired gut barrier. So, it's like everything is interconnected to everything. And this is just showing you that when you go from normal reproductive years into menopausal transition and your hormone levels are going down, you're changing your gut microbiome, you're getting more impaired gut barrier, leaky gut, and the little blue cells that you see there in the gut lining, those are the enterocytes. They're the cells that make GLP-1, glucagon-like peptide. That's another peptide, right? And those poor little blue cells that make GLP-1 start to disintegrate. So women lose their control of appetite, glucose regulation, and so on as they actually have this gut problem and dysbiosis, and the enterocytes that make in the gut that make GLP-1 actually disintegrate. If you look at the oldest set of women there that are into their 70s, those cells are gone. So you have total dysregulation and you don't have any GLP-1s anymore. That's one of the reasons, among many, why diabetes increases so dramatically in women as they transition into menopause. And here you can see the link between the vagus nerve and the gut. It's bidirectional. There's efferent and afferent, and the signals from the gut go to the brain. And when you have neuroinflammation, that's underlies having night sweats and hot flashes with infectious diseases like malaria. People can get night sweats and hot flashes. Certain cancers like lymphomas and leukemias can give people, like autonomic dysregulation, and they can get neuroinflammation, inflammation in the thermoregulatory section of the hypothalamus, creating this dysregulation of core body temperature and causing night sweats and hot flashes, which are very similar to what women get in the menopause, the vasomotor symptoms. So other things besides going into menopause can cause vasomotor type symptoms, night sweats and hot flashes, and that can be cancers like lymphomas, leukemia, and various pathogens, infectious agents that cause neuroinflammation of that area. Estradiol controls the whole immune system and controls inflammation. So think also of having the vasovagal symptoms as a sign of neuroinflammation. And so that you can see it's all complex, all interconnected. So all that you do to help heal the gut and get the gut microbiome right and heal leaky gut for women who are transitioning to menopause is critically important for every aspect of their health, including controlling vasomotor symptoms. And this is just showing the links between all of these things. And you can see it says hypothalamus, and all of these centers are connected. It's, so you can never find anything, I think, that isn't connected in some way to the gut microbiome. And once again, you want to have your patients eating lots of fiber foods, maintaining the proper microbes so that you can maintain the connection with the gut and the brain so that you don't have inflammation inducing the worsening the vasomotor symptoms. And vasomotor symptoms, I mentioned a lot of this, they're associated with really bad health status in women. They're not just about being uncomfortable or being wet. Women with high rates of vasomotor symptoms are prone to more hypertension, myocardial infarctions, strokes, depression, anxiety, dementia, skin wrinkling. That'll get your patients wanting to do the right thing. Osteoporosis, weight gain, diabetes, sugar dysregulation, joint and muscle pains and aches. So I recommend that everyone do all the lifestyle stuff. And you probably don't need me to teach you all the lifestyle, but you want to do everything to improve gut health, targeted supplementations. We do a whole reset in my office using things like L-glutamine and DIM and milk thistle products, sulforaphane, all these things to help with gut, liver detoxification pathways. And all the nutritional companies, the nutraceutical companies sell these different plans to help with gut restoration. You want to have time-restricted eating so that they don't eat randomly, don't eat late at night. Get light therapy, because light also, remember, there are receptors in the brain that go into the hypothalamus. That's where the master clock is located, sitting atop the optic nerve in the hypothalamus to help to maintain proper circadian rhythm. That is very key also to maintaining proper thermoregulatory system function. And you want to make sure you do everything to optimize sleep and exercise, avoid endocrine disruptors and toxicants, and of course, give hormones, okay? And think about vagus nerve stimulation, adrenal adaptogens, and everything you can to increase vagal tone. I recommend a lot of fiber foods, and they're things like vegetables, whole grains. Now, I realize people who have SIBO and SIFO, you got to obviously have individual variation here. So I'm talking about generally people who can tolerate these foods, because these fiber foods will really, they're dense in phytoestrogens and fiber and a lot of micronutrients to really help restore the gut and reduce inflammation. And of course, no ultra-processed food. Don't forget the phytoestrogens. They're like unbelievably important. I do hour-long lectures just on specific foods and phytoestrogens. I mentioned about eating. Try to eat more in the morning, less at night, no snacks. Fast for at least 13 hours, but you don't have to go much more than 13 because you get diminished return on investment. And try to have your patients, if possible, not skip breakfast. I mentioned light, watch the sunset, get a light box. I recommend the Happy light box to so many of my patients. You do 30 minutes at 10,000 lux, L-U-X-E, that's the measure of light energy, to 30 minutes in the morning, at the midday, and then this is where the finesse comes. For women who are waking up at 2, 3 in the morning, they're getting sweats. If you have them do 10 to 15 minutes of light at 10,000 lux with the light box 2 to 3 hours before they go to bed. It helps with their phase disorder. So it helps to shift the phase so that the brain will stop thinking that 3 o'clock in the morning is actually 6 o'clock. These are women who have phase sleep disorders that are circadian rhythm dysfunction due to estradiol insufficiency. And this will definitely humongously increase vasomotor symptoms. So think about using the light boxes and do everything to promote sleep. Check for sleep apnea. The incidence doubles at menopause. Get a fan. I sleep with a fan I love it. It feels like an ocean breeze on me. I almost always use a fan. I have a stand-up one. Do things to lower stress, relaxation time. Start 2 hours, 1 to 2 hours before bedtime. Avoid screens if possible. Make the bedroom really comfortable. Exercise actually can help reduce vasomotor symptoms. So everyone should get on an exercise program that's fun to do to their optimal extent that they can tolerate without injury, of course. So I usually do recommend trainers to begin with. Avoid toxicants, chemicals, endocrine disruptors are obviously not going to help matters. And we don't have time, obviously, to go into how I would recommend. Some of you may know, but what I recommend in a nutshell would be levels to get your estradiol level to be somewhere between 80 and 150 picograms per mil to tolerance and comfort, and using progesterone, which I also measure progesterone cyclically, I recommend, where you give typically 200 to 400. Usually I just give 200, but occasionally you have to go higher, like they do in infertility clinics, of progesterone vaginally as opposed to orally, because now we know, I mean, oral goes through the liver the first pass, just like estradiol goes through the first pass, and 80 to 90% of progesterone is metabolized into other stuff, predominantly allopregnanolone, but 30 different things. And you don't get enough progesterone and you get too much of the metabolites, but more on that another time. So, but hormones are the best and the master of everything, master of metabolic homeostasis and the masters of thermoregulatory center of the brain. So doing all these things, using light therapy, exercise, socialization, eating at the right time, working on stress, giving estradiol will help to keep all the systems, the vasomotor symptoms down and allow people to have a quality of life. So no one ever has in their family a situation like I had with my grandmother. To lose my grandmother to vasomotor symptoms and menopause is just unthinkable. It changed the life of my family forever. My father was just, never, he was right there. So you can imagine the impact it had on him. So vasomotor symptoms are not insignificant. They're huge issues. And every woman needs to be treated. Almost all women going through menopause will suffer from vasomotor symptoms and all the other things that come along for the ride, all the other metabolic dysfunctions that are associated with significant vasomotor symptoms. And for any of you out there, that's my little QR code. If you scan it, I have free ebooks that I wrote on menopause, lifestyle and menopause, and thyroid if you're interested. And it accesses all my free stuff that I have. And those are the books that I've written to date. Hope to write more. And thank you for staying with me this long and understanding that, this is very personal to me, vasomotor symptoms. And I hope that you will see the huge importance that the vasomotor symptoms have, the importance of menopause, the importance of this time in a woman's life, and that you will be the doctors who are there for these women who desperately need you and help to educate other doctors who just quite haven't gotten the word yet. So thank you so much.
Thank you. Okay. Dr. Neri, you got any questions online?
Yeah, you want to knock
Yeah,
the chat first, or should I go first?
You go first.
Okay, so Dr. Gersh, that was awesome. Another good education from one of the experts here. So one of the questions here, as we notice that women does not have that specific timeline when hot flashes occur for them. And the bigger question here is there's so many theories, genetics, races, as you said, and even metabolic health. But in your experience, why do women have severe symptoms while others barely notice menopause, and even timing is different? What do you think is a bigger contributor to that?
Um, Ovarian inflammation is a big one. Okay. And then the other one would be neuroinflammation. So when you think about, I mean, other than like what happened to me, where I had a tubal ligation and suddenly, I guess my ovarian blood supply was diminished to the point where my poor little ovaries gave out. But in general, when you have inflammation that's systemic, don't think the ovaries escape it. They've actually done studies where if you pull out follicular fluid from around the eggs, that there's actually they're impregnated with the mononucleosides of the all the leukocytes, all the immune cells. It's inflammatory fluid. So the bottom line is the ovaries of women who are unhealthy, they have environmental toxicant that are too high. They have the wrong diet, they're sedentary, they're overweight, and that type of thing. All of those things will create inflammation, and that inflammation affects the ovaries, and they'll put out hormones differently. So that can, and when you have problems with inflammation in the ovaries, you don't produce progesterone properly. That's what underlies a lot of women's menstrual problems, like having very heavy bleeding or cramps. It's because they actually don't make enough progesterone to properly have secretory conversion. So, and then when you have inflammation in the brain, it's going to affect the thermoregulatory centers of the brain, and they'll become dysregulated, similar to if you have an infection. Brain trauma can do that. And if you have certain cancers where you get neuroinflammation, all of those things, anything that creates neuroinflammation, that's why I want to make sure people realize that neuroinflammation can also, from any source, can trigger this dysregulation of the thermoregulatory system and can induce, similar vasomotor symptoms with night sweats and hot flashes. So I think that's what underlies is the overall health of these women really portends to whether they'll have bad symptoms. Then also the diets, like I mentioned, phytoestrogens. Women who eat a really healthy plant-based diet with lots of different phytoestrogens, like soy, like the Asian women, they tend to have much less in terms of symptoms. And if you look at what we know are risk factors like obesity, smoking, things that create inflammation are definitely risk factors. So the healthier you are before you go into perimenopause, the less likely that you'll have these problems. But I think that some of it is also genetic luck. I think there's something genetic as well, because we know that there is some connection to what happened to your mother. That seems always that genetics have a role. So women whose moms had really bad menopause experiences, with vasomotor symptoms, are more likely at risk. And it could be environmental as well as genetic.
Right. Yeah, and we always talk about mitochondrial health, inflammation, and those are things that we definitely need to optimize before we get into that menopausal,
Absolutely.
perimenopausal phase as well. Another question here. So we're talking about estrogen, progesterone. The curiosity here is, does testosterone help with the hot flashes? I'm thinking they're probably thinking
They
about
do.
testosterone aromatizing to estrogen. I mean,
Yes.
yeah, tell me your thoughts on it.
So it's very interesting. In men and women, many of the testosterone receptors in the brain are located right next to estradiol receptors in the brain. They're like a lot of the effects of testosterone are through just like you said, aromatization into estradiol. So I think so that testosterone definitely can help. We know, for example, men who go through, like when they have prostate cancer and they go on the drugs that block their ability to make testosterone, that's a very hard thing for a man to have that happen. But that's the, hormone blockers, but that are given to men to block their ability to make testosterone. I'm not sure that that's really a good approach, but that's a story. Maybe you guys have talked about that. Blocking testosterone in men who have prostate cancer. Those men often get night sweats and hot flashes. I'm glad that you brought that up. But it's predominantly through their conversion into estradiol in the brain. The brain is a master organ of paracrine production of estradiol from testosterone. And that's a definite way that men maintain many of their brain functions is through the conversion of testosterone. That doesn't mean testosterone doesn't have its own unique benefits and receptors, but it's hard to separate them sometimes. Like when you find that the receptors are right next to one another and the enzyme aromatase is sitting there ready to make a conversion, it's hard to always know like what's from testosterone and what's from estradiol.
Right, right. And that's why we have the symphony. You always know about estrogen, testosterone,
Absolutely.
progesterone working all together, right?
Absolutely.
Another curious question here. Other hormones. So we spoke about progesterone, estrogen related to the manifestations of these VMS symptoms. What about insulin? What about cortisol? Basically, carbohydrate metabolism, stress induction of cortisol. What are the factors that how they contribute to the VMS manifestation of patients?
Well, if we look at cortisol, when I showed, there was one slide, I didn't want to spend too much time because we'd be here too long. But when you look at the entire, like the symphony between the gut microbiome, the vagus nerve, the sympathetic ganglia, and the hypothalamus of the brain, you also then have to put in the adrenergic component, which is, of course, adrenergic as in adrenal. And when you have over stress, when you have too much sympathetic output, which happens when you have dysregulation of the gut microbiome, when you don't have enough estradiol, when you have chronic states of inflammation, and you get this like roundabout everything. It's efferent and afferent fibers from the vagus nerve to and from the brain, the hypothalamus, the gut, and the stress response, sympathetic overdrive, includes adrenergic activation of the adrenal gland, and the adrenal gland, with the cortisol production, is also heavily linked to control of the circadian master clock, which also is very involved. It's so complex, it's very involved, and estradiol has receptors in the master clock as well. So it's very interconnected. That's why women who have high stress and have high cortisol, which will then increase insulin resistance and also increase leaky gut, will impact in the hypothalamus with the circadian rhythm, and also over time creates more inflammation and neuroinflammation. So absolutely, all of these things are interconnected. That's why it's not simple. It's not like, that's why there's never going to be truly, here's like the magic pill that fixes everything, because it's just too complex for that. But yes, those hormones are very interconnected as well. And we know that, like you mentioned, mitochondria. Mitochondria, you can't run the cell machinery without having proper mitochondria creating energy. And glucose is generally the preferred energy source for the brain. With menopause, the glucose transport system into the brain doesn't work properly, and the brain is not good at utilizing glucose as an energy source. That's why people talk about ketogenic diets for people who are having cognitive problems, because the system, and they talk about dementia as like diabetes 3, because it's really related to glucose metabolism, which of course is interconnected with insulin. So yes, and when you don't have proper glucose transport and you have insulin resistance, insulin rises, and then insulin creates over chronic levels of insulin create more inflammation as well. So yes, these are all interconnected, and the thyroid hormone has receptors everywhere. And it turns out that estradiol is critical for thyroid receptor function. There's also estradiol receptors on the thyroid gland. So they are all interconnected. Absolutely. That's why women who have hyperthyroidism, they'll have night sweats and hot flashes, because they sweat like crazy, right? Their regulatory centers are dysregulated when you have hyperthyroidism, and hypo, they feel cold all the time, So 100%, all these hormones are interconnected. But I always look at estrogen as sort of like the master of metabolic homeostasis because in some way it regulates all of these hormones, but they're all intertwined.
Right. I agree. And even when you mentioned about estrogen receptors all over the place, circadian clocks, as we always thought, only just
Yeah,
in the pineal gland, it's all over the body,
it's
different
everywhere.
organs. Yeah, they have circadian clocks in every organ.
That's right.
Separate.
In fact, when they look at the clock genes, something like a third of all genes in the body are clock genes. And when you look at associated with clock genes, so genes that are not clock genes, but they're associated with clock genes, it's 90% of all genes in the body. That's how critical circadian rhythm is.
Right. Dr. Bell, you want to insert some of those chat questions?
Yeah. Dr. Biley remarks vasomotor symptoms make him think of a loss of nitric oxide. Is that a possibility?
Well, nitric oxide is critical for brain health, for vascular health, and we look at like the enzyme, there's endothelial nitric oxide synthase to make nitric oxide in vessels and neuronal nitric oxide synthase in the brain. So there's no question nitric oxide is like a hormone. It's an antioxidant, it's a regulatory agent, and everything depends on nitric oxide. So we didn't get down to the nitty-gritty cellular level here, like we just touched on mitochondria. Mitochondria can't work properly without nitric oxide, so 100% nitric oxide is critically important. Estradiol is what modulates the enzyme systems, nitric oxide synthase, to make nitric oxide. And of course, when you don't have the right gut microbiome and the right gut and the right gut types of nutrients that are in there, and also the oral microbiome. If you don't have the right oral microbiome, then you don't make nitric oxide through the alternative pathway. And estradiol is critical for all the microbiomes, including the oral microbiome and the entire gut microbiome. So all of these things are interconnected. So two thumbs up for nitric oxide, 100%.
Okay. So you mentioned a number of times that you like the estradiol levels between 80 and 150. How do you get there? Let's say
Well,
I have a serum level of say 15, or I'm not sure what a saliva level would be, but how do you get there?
well, if I'm starting with someone that's recently menopausal, okay, or they're perimenopausal is another thing because there it's supplementation and that their own hormones are still being made. It's just probably not adequate, right? But if we take someone in menopause where it's flatlining, they're not making anything. So there's no protocol, as you know, there is no written protocol because the standard of care is not to give hormones for optimal health. It's to give hormones to suppress vasomotor symptoms, night sweats and hot flashes. That's the only reason that all these organizations, all those menopause societies that I mentioned, that's still their goal. It's just suppressing those symptoms, and that's not enough of a dose to optimize bone health and brain health and so on. We know that doses, at least we have a lot of studies or medium number of studies looking at bone health, how directly related the level of estradiol is to actual growing bone and maintaining bone optimization. So you have to find what you're comfortable with. For young women, if I'm going to give, and I use all estradiol forms, like I use compounded plenty of times, but I also use the commercial products, the patches, and the gel. I don't use the spray because the Evamist to me, when I've looked at all the data, you can't get levels anywhere high enough. The levels are so low. They're still often in the menopausal range, even after 3 sprays, so I don't use the spray. So I just use the patches or the gel. And when you use the patches, there's some data that if you give up the 0.1 patch, you can get levels not in all women, because the skin is a barrier. So you never know what someone's going to get based on what you give. You never know what's really going to get into the blood. You have to measure, but that's not the standard of care. The standard of care is you don't measure. You just give enough, it's still the least amount, just to suppress.
Yeah, but I'm asking you, what's your standard?
Okay, what I do is,
We want the Gersh standard.
okay, the Gersh standard. I just always now you know the standard of care, which is nothing.
We all knew
Okay,
that.
you all know that.
Yeah,
So
but
what I do is, and
we
a
wouldn't
young
be
woman.
here.
So I'm not afraid of hormones at all. Okay, like I say, there are many things to be afraid of. Bioidentical hormones don't deserve to be on that list. Okay, so I'm not afraid of them. So with a younger woman who's like recently, when I say recently, I mean less than 5 years, okay, into menopause. If I'm going to use the patch, I usually start at the point one and I tell them, look, if you have too much breast tenderness, it's not dangerous. Maybe you need more iodine, or maybe you should stop drinking so much coffee. We have to look at other reasons why they would be sensitive. I also find that some women will have more breast tenderness if they use the patch, maybe because of the way it's released, but then they do with the gel or compounded. So if they have too much breast tenderness, it's maybe the patch isn't really for them. I don't think there's anything published, but I certainly have seen that you also absorb better from the patch if you put it on the upper part of the butt rather than on the tummy, but you don't sit on it. So for some reason, the skin there absorbs better from the patch to get higher levels if you just can't seem to get the levels up. But from the data, the 0.1 patch can, in many women, get to about 100 picograms per mil. So for many women, it's just one and done. You give them the 0.1 patch and they do fine. If they're too sensitive and they say, oh, I have so much breast tenderness, I mean, you could start them at the 0.05 patch and then work up to the 0.075 after, say, 2 cycles, and then go up to the 0.1. There are a few women that actually get good levels. It's very rare on 0.05, but usually with 0.05, you're not going to get much above 50. So sometimes you get even well below that. In the KEEP study, they used 0.05, and the highest level they got, and they measured, was 40 picograms per mil. So it always stayed in the menopause. Anything below 50 is still menopausal level. It just stayed in the menopausal level. In terms of the gel, I usually start at either the 1 or the 1.25 milligrams for younger women. It's a little harder, with a patch, it's a little off label, but you can cut it. It's still fine with the matrix dot patch, you can cut it. And so if I say, well, if feels like it's too much, you're having too much breast tenderness and would just want to try it, then just cut like a quarter off, so I'll do that. But I don't want to start low and just spread it out. I want to get results, and I want to get results fast, and I want to get effects on the brain and the bone, and I want them feeling better as fast as possible. I don't want to, we know that you can give tiny doses of estradiol and it will take like 3 months to see any results. That's not my goal. I want to get results fast. And I'm not, like I said, what am I afraid of with hormones? Breast tenderness, bleeding. I know how to deal with all of those things. So none of those are dangerous. And with the progesterone, I just typically start them right out with 200, tell them to try it intravaginally. When they do it vaginally, and I know that everyone's not doing that, but I hope everybody will, and that they'll tell women that bleeding is just how you're made. You can't get growth factors if you don't have enough to grow the uterine lining. You're not going to have enough growth factors for brain-derived neurotrophic factor, nerve growth factor, transforming growth factor, vascular endothelial growth factor. We need growth factors, and you can't get, the growth factors are going to go to the uterine lining and they're going to proliferate, grow the uterine lining. If you keep suppressing the uterine lining by giving progesterone every day, then progesterone downregulates the alpha receptor of estradiol, which is what is involved in growth factors. So basically, that regimen of nightly progesterone is designed to suppress estrogen's benefits. You're going to suppress growth factors. Well, I want growth factors. I want to have repair. I want to have maintenance and rejuvenation. You need growth factors. So if you suppress them in the uterus, you're suppressing them everywhere. Progesterone's going everywhere. And it's a balance. That's progesterone. after you ovulate in the menstrual cycle and you make progesterone, it's progesterone that stops proliferation. That's why the uterine lining stops growing and then becomes secretory. But we don't want to stop that's why you have to have a cycle. Nothing should be all the time. You grow, you don't grow. You shed, that when you shed, there's studies in menstruating women that when they're shedding their lining, they're also shedding bad cells, senescent cells elsewhere in the body. And estradiol regulates the entire cell cycle, which is really regulated by mitochondria. So you're also getting rid of senescent cells. Estradiol is a senolytic, but you have to have the cycle and you have to have the dose. Dose matters in everything. No one says 5 minutes of exercise a month is as good as 30 minutes 5 times a week. I mean, come on, dose matters. So if you give enough estradiol, you're going to grow the uterine lining. And if you grow it, you have to shed it or it's just going to bleed irregularly. And then you give the progesterone for 14 days vaginally and you get incredible levels that are physiologic and you get complete secretory conversion. All infertility centers, all IVF centers use vaginal progesterone. There's a ton of published data on vaginal progesterone. They use sometimes 400, 3 times a day, vaginal progesterone. So I start with 200, and if their periods are too heavy, the pretend periods, are too heavy or they actually have cramping, it means you need to give more progesterone. You need to give more because you're not getting complete secretory conversion. When you get complete secretory conversion, the uterine lining will have like a plane, just like in a navel orange, you can get the orange and the peel separated easily when you have a good plane. If you have a good plane, then the uterine lining will just come right off and just come off and you'll have less bleeding, less pain. If it comes off in little dibs and drabs, then the uterine lining will they'll have bleeding. You'll have more bleeding because it's coming off in little pieces instead of just coming off altogether. And then the uterus says, get out lining. And then you have to have cramp. The uterine muscle has to cramp more. It's like a mini version of labor. It's like, get the baby out, cramp. Get the uterine lining out, cramp. So you want to have it easy, that you want to create that proper perfect secretory conversion. That means you have to get estradiol levels up. In a normal menstrual cycle, progesterone levels can be very variable, but they're always going to be over 10. It has to be over 10. So you got to measure progesterone. It has to be now, if you're giving it at night and then you're measuring your progesterone in the morning like I do, then you have to have a little leeway because you're going to be past the peak level. So if they're getting regular cycles and they're good and they're not too heavy or anything, and their levels are like over 7, then that's probably adequate because it means it was much higher just a few hours earlier. Okay. So and then women have to, if it's how you present it, it's all how you frame it in your mind. So I say, when you have this bleeding, it's a small price to pay for having optimization of hormones and all the things that they do. And taking hormones in tiny doses, not enough to grow the uterine lining, and then suppressing it every day with progesterone, it's like, what's the point? You're giving an inadequate amount of estradiol and you're giving progesterone to suppress the growth factors every day, but you will suppress night sweats and hot flashes. So I always say, what's your point? Why do you want to go on hormones? If it's just to suppress night sweats and hot flashes, then any hormones will do for any period of time practically, for any dose. But if your goal is optimization, dose matters, rhythm matters, because you can't grow the uterine lining without giving enough estrogen to create growth factors, and that's going to need to be shed in a regular way. So it's how you frame it. Women, if you say it's very abnormal to have a period after you're in menopause, well, I'm not going to say it isn't, but so is giving hormones. So is living to 100. Nature never expected that we would live to 100 in good health, right? So we're trying to be smart, but we can't totally outsmart nature. We have to live within nature's guidelines. So I always say the biggest failed experiment of we're smarter than nature, like we give, abnormal, completely unnatural hormone regimens to women that never exist in nature. The biggest failed experiment was we can create food that tastes better than natural food. Like we'll put in more sugar, we'll put in more salt. How's that worked out for us, right? We can create food that never spoils. We'll just put in trans fat, right? then we can eat Twinkies in 100 years. How's that worked out? I think we
There's a
just
problem
have,
with that.
I don't know. I'm waiting for that 100-year Twinkie, you know?
So the Twinkie will last 100 years.
Yeah, but we won't if we eat trans fat.
Question about transdermal nitroglycerin for vasomotor symptoms.
Never used it. I would probably say we have better solutions.
Okay. Okay. Geraldine Pryor just published that if the effectiveness of oral progesterone, 300 milligrams to resolve vasomotor symptoms. Also that women have the highest estrogen levels of their lifetime in the perimenopausal years. So adding estrogen can cause more problems.
So let me do the second one first. So first you have to think why, I mean, there's no published data on this, but I use it in my practice, okay? Why do women have these crazy swings? So what happens is the eggs themselves are now aged. So you have older eggs that are not as functional, but they're still there, right? And so it's harder for the brain to, through the pituitary, to get the eggs to make estrogen from the ovaries. So you have the rise of FSH and LH through the pituitary, but the signals are coming from the brain, from the hypothalamus, through the gonadotropin releasing factors or hormones. So the bottom line is the brain has sensors to estradiol. The brain has no sensors to testosterone, just so you know that. That's just a side note. The brain has sensors to estradiol. The estradiol production starts to go down. So the brain wants the ovaries to make estradiol because it senses there's not enough. So it puts out normal amounts of FSH and LH to try to get the ovaries to make more estradiol. But they're like old eggs and they're resistant. So they don't respond well. So the brain says, all right, I'm going to put out higher levels of FSH and LH to get the ovaries to make more estrogen. And it doesn't respond. Then it puts out more. And then there's like a surge of FSH. So it's like a hyperstim. If you are involved in egg retrieval for either egg freezing or IVF, they'll give high levels of FSH. And so when you give these high levels of FSH, then what happens is the ovaries finally respond and they go through and they like oversurge and they put out, you'll get 800 picograms per mil of estradiol. But the reason is because the brain has sensors and it's not getting the estrogen it needs to tell it that everything's fine. So it keeps trying through the gonadotropins, raising the gonadotropins to get the ovaries to make more estradiol. And then the eggs finally respond with this dramatic overshoot, of course, and then it goes down. So then it goes up and then it goes down. The trend is generally down, but you have these big ups and downs. If you give some estradiol, the brain sensors will never have to do this. They won't have to go, whoa, up and down, trying to get the ovaries to make more estradiol. So if you give a background amount of estradiol, the sensors in the brain won't need to put out more gonadotropins, and then you won't get that overshoot. And you can actually reduce these crazy swings by giving the background estradiol. Now, is there published data? No. So I'm telling you personal anecdotal data, okay? But it can be dramatic for some women that, now, if you don't want to do that and you're monitoring, like say they're doing one of the kits and they're like monitoring their estradiol levels through urine metabolites, if they want to do that, then just give the progesterone, and you can give the progesterone for 2 weeks, give it once again vaginally, and that will help them to have more regular periods. And also, as luteal phase defects are very common as women age because their ovaries are not making progesterone properly. It's just like everything's getting old and it's not working as well. So you'll get better results and better periods and more regular that you can get predictable periods by giving the progesterone. But the reason I give estradiol in perimenopause is that the general trend is down. You get these big spikes up. But if you give background estradiol, it's like a safety net for the brain, for the sensors, so that it doesn't have to do those giant up and down regulation type things to try to get the ovaries to make more estrogen. In terms of progesterone, it turns out that many hormones, like you mentioned testosterone before, we have data you can give progesterone. You don't have to, I mean, give 300 milligrams, even much less than that will often suppress night sweats and hot flashes. I had one slide that just barely mentioned it, but there are progesterone receptors throughout the brain and in the hypothalamus as well, and also in the thermoregulatory centers. So progesterone can actually act on the thermoregulatory centers. Now, one of it's that when you give oral progesterone, I mentioned 80 to 90% of it is metabolized into other stuff, metabolites, over like 30 of them, the dominant one being allopregnanolone. Now, in the brain, we have the neurotransmitters. We have the activating neurotransmitter glutamate, which is activated by estradiol predominantly. And that is what you have that gives you focus and memory and alertness. The drug that activates glutamate is they're amphetamines, right? So that you take amphetamines when people take them, for like Ritalin, like for ADHD, to give them more focus. They give it to pilots and other types of long haul truckers, so they don't fall asleep while they're flying their plane or driving a truck or something, right? I'm not saying it's right or wrong, but that's what's done. And to keep people awake and alert. Well, progesterone, through its metabolite, allopregnanolone, activates GABA. GABA is an inhibitory neurotransmitter and is very sedating. So through allopregnanolone, when you take progesterone orally, you make a lot of allopregnanolone. And allopregnanolone is really good. The problem with too much allopregnanolone every day is that it activates GABA, the GABA A receptor, which is inhibitory. There's data in rats that if you have chronic exposure to too much allopregnanolone, the rats actually get dementia. In humans, there is published data that too much allopregnanolone can impair memory formation. So when you take too much oral progesterone on a regular basis, you're giving so much allopregnanolone to the brain, you're activating too much GABA. Too much of a good thing is a bad thing, and you get too much inhibitory. But if you're just giving it short term, that it's inhibitory, it's going to downregulate many of the receptors, and it can roll over into the thermoregulatory centers to some degree. And I don't think there's a whole lot of research on that. But that's what I think is happening, as well as the fact that there's direct receptors for progesterone in the thermoregulatory centers.
Okay. How you doing? There's a number of questions left, but
Well, I don't know how the audience is doing.
well, we've
I'm fine.
lost some. You're okay?
I'm okay. I know I look a little tired, but I'm recovering still. I didn't tell you what happened to my plane. We boarded my plane to get home from Las Vegas, and after we're boarded, we started pulling out from the gate, and there was a big bang sound. And the pilot came on and said, "You probably heard that bang sound." Well, that was the starter. I didn't know that jets had a starter. They said, we can't start the engines. There's nothing wrong with the engines. We just can't start them. So we're going to have to get towed back to the gate, and then they're going to see if they can fix it. I knew that was hopeless. I was on the last flight out. But then what they ended up doing was I call it a Christmas miracle. They had us deboard the plane, and we went to a gate that was like a few doors down from our gate, and there was a whole group of people lined up to get on a plane to fly to LAX. I was flying into John Wayne, and they told everyone from the LAX plane to go sit down. They gave their plane to my plane passengers. So my group of passengers from my plane stole the plane from the LAX passengers. We got on the plane. We flew back to Orange County. They kept the airport open for an extra half an hour until almost 11:30 at night. And I have no idea what happened to those people trying to get home to LAX. They had no plane. But anyway, by the time I got to bed, it was well past 1 a.m. and so I'm still recovering.
They knew you were, VIP coming back from,
Yeah, right.
conquering
So
war.
anyway, but I'm still
It-
hanging in there.
there's a discussion in the chat about soybeans and stabilizing glucose um delaying gratification and high IQ. I'm not sure, what that's all
I'm
about.
not sure about delaying
Yeah,
gratification.
I'm not sure what that's all
And I'm not
about.
sure about high IQ, but
Yeah.
I think the more
Okay.
phytoestrogens
Um,
you eat, it's good for
there's
your
a
brain.
thumbs up here for more omega-3s than omega-6s. Nobody in the US does that. How much testosterone are you giving? And what is your opinion on biased 50-50?
Okay, testosterone. We have very limited data on testosterone in women. The only FDA approved use, not that we necessarily care, is for hypoactive sexual desire disorder and kind of low libido. And we have no guidelines at all. So I had to make up my own, just FYI, because there are no guidelines. So if you look at the reference range for testosterone, depending on the lab, it's somewhere in the neighborhood of 3 to 50. Okay, that's in that range. So I just figure you don't want to be in the bottom half. That's what I figure. Okay, why would you want to be in the bottom half? You don't necessarily want to be in the very top either. That might include women with PCOS. You don't want to be in the very top. So I figure you want to be like maybe between the 50th and the 70th percentile. See, I made that up. Okay, so if you have
We've
that
only,
range,
we,
maybe you
I've been
want to
doing
be
this
in
for
the 20.
25 years. We usually shoot for about 30 to 40 on total, and
Okay, so I was going to say 25 to up to the upper 30s. So not too different.
yeah, 2 to 4% on the free androgen index. I know that's one you probably don't like.
Well, because the problem is that the testosterone levels are so low in women that the assays for total testosterone are borderline accurate,
Yeah.
let alone looking at teensy little free testosterone. But I like to look at sex hormone binding globulin
Well, that's
because,
what, yeah, that's what we use.
yeah, I know that's what you use when you compute it, right? So sex hormone binding globulin, so 99% of testosterone is bound in the blood, mostly to sex hormone binding globulin. When you lose your estradiol, sex hormone binding globulin declines because that's a very key thing. That's actually how birth control pills work. The ethinyl estradiol in birth control pills is very powerful for increasing sex hormone binding globulin, which binds up the testosterone, which can improve acne. So that's the main mechanism. Okay, so but natural estradiol, bioidentical estradiol, will also increase sex hormone binding globulin. And when you have reduced amounts, sex hormone binding globulin goes down. So if you have less sex hormone binding globulin, you're going to have more unbound testosterone available to the tissues. So it's a little tricky because you can have normal or even a little bit lower levels of testosterone, but you have more unbound. And that's why many women around perimenopause actually develop acne and start growing whiskers. And that the last thing they want or need is more testosterone. What they need is more estradiol, more sex hormone binding globulin, so they have less unbound testosterone. And that's when women start having androgenic alopecia. So, and then the last, and especially some women are high converters of testosterone to dihydrotestosterone. And so you start increasing their testosterone level, they're going to grow more hirsutism, they're going to get acne, they're going to get thinner hair. Oh my gosh, you're going to be very unpopular. Okay, so I think there's an overplay of testosterone, and there's some evidence that testosterone levels actually increase in women in their 60s. Isn't that weird? And also the production, but their sex hormone binding globulin, if they're not on hormones, is going to be really low. So they're going to have a lot of unbound. That's why if you go into a nursing home and you see the little old ladies, um, they're all going to have like little whiskers and they're going to have really thin hair. You can see all their little wispy hairs and all their scalp, and they're not on testosterone. They just have no estrogen. They have really low sex hormone binding globulin, and they have too much free testosterone, and that's why they get whiskers. I mean, so testosterone is not the solution. And then you have to know, where is testosterone even coming from? 75% directly and indirectly from androgen precursors comes from the adrenal gland and 25% from the ovaries. And the ovaries can make testosterone forever. You don't need a single egg to make testosterone. So testosterone does not go down at menopause, and it may go up because the gonadotropins are higher, right? You have higher LH because testosterone in the ovary is the precursor to estradiol. All estradiol in the ovary is made from testosterone that's made in the ovaries.
I
All
don't
of
know.
it.
Maybe it's where we live. I see patients all the time where their testosterone levels are essentially zero.
Well, you have to look at, so yeah, well, women can have all different levels. And if they need it, I prescribe testosterone. I don't want to give you the impression. I'm just saying that I don't think it should be a reflex. You know, they hit an age and you just give them testosterone. Okay. I think you really have to think this through. Like, the zona reticularis is the area of the adrenal gland that makes androgens. We know from imaging that as you age, it shrivels. So testosterone levels, as a general statement, do decline with aging, but not at menopause. In fact, they may have increase in menopause because of the increase in LH. So just individualize it. And then what I do is I give cream. I don't use pellets. Pellets are uncontrolled and almost always super physiologic dosing. So I don't personally use pellets. I give creams where I can start low and then raise it. Like I can start with 1 milligram cream twice a day. I can go to 2 milligrams twice a day. I can go to 3. So I start low and I titrate up. Unlike estradiol, I don't want to start too high on testosterone. There's no emergency testosterone situation. There just isn't. So I would start low, see how they tolerate, go up another milligram, go up another milligram. Generally speaking, the highest you should ever go is 5 milligrams twice a day. That would be a total of 10 a day.
I disagree with there's no emergency. You bring us one of our postmenopausal ladies who's had adequate testosterone and then it drops off. And they call up and say, it's holiday time. This is an emergency. So
Well, I would say that's a little different. When women go, and I'm talking women who are not on testosterone, they didn't have, unless their ovaries are, no, I have to make a thing. If you have your ovaries removed, like you have a hysterectomy, if something's wrong with your ovaries or whatever, and they don't do this so much, but you have an oophorectomy. The ovaries make 25% of the testosterone. And there's no compensatory mechanism for the adrenals to make up what you lost. And the brain in the women has no sense, there's no sensors in the brain for testosterone at all. So if the testosterone drops, the brain does nothing to compensate. The adrenals will not compensate. The ovaries are removed, you're down 25% instantly. All those women need testosterone. That's an instant drop. If you're on testosterone and then you suddenly stop being on testosterone, that's an instant drop, okay? But if you just are aging naturally and your body maybe is making less over time, it's not going to go shoop like that. So that's why I say for natural women who are not on testosterone, there's no testosterone emergency, okay? But if your ovaries are removed, you need to get right on testosterone. And if you're on it and then suddenly you stop taking it and you go like that, that's going to give you a problem. So you need to get right back on it.
there's a question. What's the highest dose of progesterone you've ever prescribed and also estrogen?
400 of testosterone, 400 of progesterone, 400 milligrams is my highest that I've gone. And for estrogen, probably like 5 milligrams twice a day of compounded is the highest. And I look at levels. So when you give compounded estradiol, it's absorbed much less well than the commercial products. And as a general statement, it depends where you put it too. Okay, where you put it matters for how it absorbs. So generally, the dosing is not comparable between like the patch and the gel and the cream. So and where you put the cream can also vary, in its absorbing. If you put it on thinner skin, it's going to absorb more than if you put it on thicker skin, right? Because the skin is supposed to be a barrier, that's why that the patent for the commercial products is not for the estradiol. You can't patent estradiol. It's for the delivery system, how to get it through the skin to be absorbed into the bloodstream. So in terms of the patch, I have used, but not that commonly, 2 of the 0.1s, for people who just don't absorb, and 2 of the highest dose gel packs I have used, but not too often because I'm not trying to super dose. I'm not looking to get 300 picograms or something. That's not my goal as a general rule, you know.
Okay. This is more of a statement, Dr. Byerly. Hot flashes are from low estradiol, low progesterone, and high or low cortisol. Any comment on that or agree?
Well, it's definitely from low estradiol, and there's less data on progesterone, but definitely low progesterone is not a good thing. For cortisol, also, my belief is that high cortisol is going to give you more hot flashes than low cortisol.
Uh, Perimenopausal patient who is symptomatic, their FSH is still below 10 to 20. Would you consider starting estradiol?
Yes.
Okay.
But I would rule out everything else. You got to rule out, they could have something else going on with them, right? So you don't want to make any assumptions. Always rule out other conditions.
Okay. What about women who are estrogen dominant? How do you compensate for that?
Well, the only time that women are naturally estrogen dominant would be perimenopause, like when it was mentioned that you get this overshoot of estradiol. And we mentioned already about that. If you have a woman who has, and I try to avoid the word estrogen dominance because, like, what estrogen are you talking about? Remember, there's like, oh, and I'll go back on the biased one. I forgot to answer that one. But in terms of estrogen dominance, it would be estrone. Okay, so women who are very inflamed, have too much adipose tissue, they're going to be inflammation upregulates the enzyme aromatase. Aromatase converts androgens into estrogens. Okay, and the dominant androgens will be like DHAS and DHEA. They convert to estrone. Okay, when you have inflammation, the enzyme that converts estrone into estradiol is downregulated. So you kind of get stuck in estrone. So when you're inflamed, you make estrone and you can't convert estrone easily into estradiol. So you're stuck in estrone. Estrone activates predominantly the alpha receptor, which is the receptor involved in proliferation, growth factors. And also, their alpha receptor is on the dominant estrogen receptor on innate immune cells like macrophages, neutrophils, monocytes, mast cells, I think I mentioned. So you end up becoming more pro-inflammatory. You're activating the innate immune cells. You're promoting growth and proliferation. So that's the perfect ticket, right, to cancer. You have uncontrolled proliferation and inflammation. And you already have inflammation. Now you're just increasing the inflammation. So what's the solution? Well, you got to do everything to get anti-inflammatory status, right? So you got to go on an anti-inflammatory diet, exercise, weight loss, work on sleep, work on stress, and give estradiol. And make sure you work on the gut because you want to make sure that as best you can that the liver is doing proper detoxification of hormones, particularly estradiol, and you want to have proper the gut, the estrobolome, so that you have beta glucuronidase, functioning properly and not over, not under. And that requires a proper gut microbiome. So it's complicated. But giving hormones, giving estradiol and progesterone will balance out the immune system stimulation in terms of balancing the beta receptor and the alpha receptor, and you'll lower inflammation. You'll improve gut microbiome status. You'll then high levels of estradiol downregulates the enzyme aromatase. Estradiol downregulates aromatase because the body is designed so that if you have plenty of estradiol, you don't need more. So aromatase production of function goes down. So giving estradiol will help to reverse estrogen dominance, if you want to call it, which I would say estrone dominance, okay? Instead of just estrogen, because people don't know what estrogen are you talking about. So if it's estrone dominance, you give estradiol to balance it all out, along with all the lifestyle stuff intensively.
And then I think this is probably along the same answer. What about severe endometriosis? So that's
Oh, endometriosis, there's very, very limited data. I just was listening to a lecture on this too, and to see about an update. And the data that is on endometriosis and giving estradiol is very poor quality research. So it's very low level, of data. So we have almost nothing on endometriosis. So what I do is, of course, the way that you get the worst scenario with endometriosis by having a lot of pelvic inflammation. Okay, so everything we can do to downregulate aromatase in the pelvis, the enzyme, when you have a lot of backflow of endometrial tissue and dead tissue lining, you have that retrograde menstruation, it creates this intense inflammatory response in the pelvis, and the inflammation upregulates aromatase. The pelvis, the peritoneum, makes estrone locally in the pelvis, and that's what creates the growth factors that feed the growth of the endometrial cells that are still living, that are now getting into the pelvic cavity. So it's complicated, and it's underlined by improper progesterone receptor function, probably from genetics plus endocrine disruptors like pesticides. And so sometimes giving high doses of progesterone can help override progesterone receptor resistance. And part of the way that it's inflammation controlled is through the endocannabinoid system. So this is where CBD and CBD suppositories and oral CBD can be beneficial to reduce the inflammation. So endometriosis is a really hard one. It is, but luckily in menopause, most of the endometriosis kind of burns itself out. But there's very little data and very poor quality data on what happens when you give patients with endometriosis hormone replacement therapy. Same thing with fibroids, very little data. So fibroids is easy. If they really grow, you can always do a hysterectomy. Endometriosis is a different animal. So you got to do everyone individually. And definitely, these are the cases where you really have to keep inflammation down, give higher amounts of progesterone, give it vaginally, and use CBD.
Okay, what about women who've had ablations?
They're my favorites, actually, because they don't bleed. I'm actually thinking that women should have ablations on demand. Women can have facelifts on demand. Why can't they have ablations on demand? Women who've had ablations, you can give them hormones and you can give them physiologic cyclic hormones and they don't bleed. And everyone is so happy.
Mhm.
I love ablations.
Since you use vaginal progesterone and transdermal estradiol, do you exclusively use saliva to monitor levels?
No, I use blood.
Okay. Okay. What about using topical progesterone?
Well, I want there to be topical progesterone. If there's no commercial products for topical progesterone, and that's not because people aren't entrepreneurial, because nobody has succeeded in creating a product that is reliably and dependably absorbed. The progesterone molecule has 21 carbons. Estradiol is really hard to get through the skin. It really is. And it has 18 carbon molecules. And the bottom line is progesterone is a very big molecule, and it's not reliably been able to be delivered through the skin into the bloodstream. If you can invent it, you'll be a billionaire. Okay, we need it.
I keep wanting to invent a bioidentical birth control pill. That's my billionaire dream.
Yeah, the reason why isn't there a bioidentical? Because progesterone has such a short half-life compared to the synthetic ones. You'd have to in order to give a high enough amount of progesterone to actually suppress ovulation. Whoa, that's like pregnancy. Okay, pregnancy, the progesterone is high enough to suppress ovulation. That's why you don't get pregnant when you're already pregnant. Okay, that it's the high amounts of progesterone produced in pregnancy that suppresses ovulation. But you can't do that. We can't give progesterone like that. You'd have to be doing multiple doses all day long to get levels that high. Progesterone levels can be like in pregnancy can be like 300. Remember, in ovulation, at post-ovulation, the levels are like 15. I mean, we can't dose it high enough to get the levels of progesterone to suppress ovulation. That's why we can't use bioidentical progesterone.
Where are we
We
getting those?
can use estrogen.
You remember the Wiley protocol, the original one?
Sure. I know it. I know it very well.
800 milligrams of progesterone, 1,000 milligrams of progesterone. I
I
see.
know. And the same thing with estradiol. The dosing of the the concept is perfect. The practicality and the dosing is untested, unpublished, and crazy. I've had patients who were on it who had levels of estradiol that were like 800. That is not physiologic, okay? And the progesterone, I wish we had a progesterone topical. By the way, somebody took out a patent for a vaginal progesterone ring. I'm waiting to see if that gets produced. Somebody has a patent on it because that would be
Don't-
easier
Don't
too.
tell Dr. Platt. Right?
Does he have it? I don't know who has the patent. I just saw
No,
that
no, not that. He's got the topical progesterones, you know.
Oh, well, progesterone topically is just not reliable. I'm not saying it doesn't get absorbed, but it's just not reliable enough.
Yeah.
I do use topical progesterone in women who've had a hysterectomy because I care less about it being perfect. I'll monitor them. I'm giving it to them. But if they just hate having vaginal progesterone, you can also give it rectally, but they don't want. So I can cheat a little bit. In women who've had a hysterectomy, I can give them high doses. I can monitor, but I don't have to worry about bleeding, like or getting cancer or
Yeah. What
hyperplasia.
about breast tenderness? Would you use topical progesterone on the breast tissue?
Some people have done that. I have not.
Uh, how about there's a question of a fourth type of estrogen for a birth control pill?
Yeah, it's already out. So in the fetal liver makes estatol. Estatol. It's a fetal produced liver estrogen. Only exists in the fetus for a very short period of time. It's a weak estrogen. In other words, it binds loosely to the receptors. It's not like a powerful binder, and it only acts on one part of the alpha receptor, but it's the part of the alpha receptor that is not the one that's activated in breast cancer. So there is research that estatol may be used as an estrogen in women with breast cancer, just diagnosed breast cancer, because it cannot activate the alpha receptor type. Alpha is not just one receptor, there's alpha, this type, like alpha A and alpha B, and it only activates alpha B, and alpha A is the one that's breast cancer involved. So, but the thing is that it's actually in a birth control pill called Nextstellis. For no obvious reason, then you can do it. I mean, they learned how to, I mean, it's a fetal estrogen. It's never, ever, ever in a human adult ever, but you can make it, you can sell it. I don't other than the possibility that it may have some use in some things, like maybe some breast cancers, but why it's in a birth control pill is beyond me, except that you can do it.
Okay, well,
They're also going to use it for menopause too. Yeah.
okay. I think that's about everything. There's maybe one more.
I was going to answer about bias 50-50. So I forgot that one. So I would never use biased. Estriol does not protect the bones. Estriol is a weak estrogen that binds predominantly to the beta receptor, which isn't a bad thing. We love beta, we love alpha. We just want everything at the right time, in the right place, in the right amount. So there's no human being that ever in their life has biased in their body. I mean, like, what are you trying to do? What is your end game? What you get usually too little estradiol, and what is this estriol supposed to be there for? You know, we have estriol always. Estriol is made from estradiol. All estriol in the body is derived from all estriol is derived from estradiol, and the body will make estriol as it is needed from estradiol if you make things right. Okay, so I'm not against estriol, and estriol is the dominant estrogen of pregnancy. The last thing I'd want is to try to recreate pregnancy. Pregnancy is a high risk situation. I'm not trying to recreate pregnancy, and estriol, by activating predominantly the beta receptor, downregulates the alpha receptor, which is good in pregnancy, because it's part of the way that you prevent the immune system of the mother from killing the fetus, because you're downregulating the alpha receptors, which are what they downregulate, in some of the immune modulator drugs for autoimmune diseases. That's why many autoimmune diseases like multiple sclerosis will go into remission. but you're also making women, just like with the immune modulators, more prone to having a severe outcome from an infection.
Okay. All right. Okay. I think we've come to the end of our questions here, believe it or not. I think we've come to the end of our video. Looks like we've got a break in our, I don't know what happened. We got a freeze.